Good evening, everyone. I am Arpita from the IGCP group, and I warmly welcome you all to today's webinar. It is my great pleasure to introduce our distinguished speaker for today's session, Dr. Soumyabrata Acharya Sir, an accomplished pediatrician and neonatologist. Sir holds an MD in pediatrics, DNB in pediatrics, diploma in child health, along with prestigious international fellowship including MRCP UK, MRCPCH UK, and MRCPE. With his extensive expertise and commitment to child health, he has been guiding both patient, parents, and the medical fraternity in understanding complex pediatric conditions. Today, he will be sharing his insights on a very interesting topic, which is GER in children, a diagnostic puzzle unboxed through a case. This session promises to deepen our understanding of gastroesophageal reflux in children, its diagnostic challenges, and practical clinical approaches. It's an honor for us, sir, to have you today with us. And without doing any delay, I would request him to please start with the topic. Over to you, sir.
Very good afternoon, everybody. Thank you for the kind words. Uh, I am Dr. Acharya. I'm attached to the Monipal group of hospitals. Basically, I'm a pediatrician with interest in neonatology. I will start with a case. Next slide, please. Uh, each case gives us a learning. I am with a newborn, especially the tiny newborn, for last 30 years, but still I gets learning from each case. So I am going to discuss one of those cases. This is a small, tiny preterm baby which was born at 27th week of gestation by emergency LUCS. The baby's weight was 820 gram, and the baby was a very turbulent NICU stay. The baby had a surfactant deficiency in lung disease. Next slide, please. Next slide, please. And was intubated and ventilated and given surfactant. Was ventilated for 1 week, followed by CPAP for next 2 weeks. Had sepsis, treated adequately. Had early necrotizing enterocolitis. Next slide, please. And the baby also needed TPN and started on NG feed as usual, which was gradually introduced, eventually went home on 6 weeks. At the time of discharge, the baby was on full oral feed, and the discharge weight was 1.4 kg. We are very happy that the baby was so tiny, so precious, and so much valuable for the parents. So we are happy the baby went home. Next slide, please. But unfortunately, one day I got a call from the A&E. The baby came with a apparent life-threatening event, which is now it is called ALTE, and the baby was apneic. When I reached the A&E, the baby was apneic, baby was cyanosed, baby was limp. Obviously, the baby was resuscitated and again ventilated. Next slide, please. Next slide. Yeah. But this time the ventilation was for a shorter time. But as per the protocol, we did a full septic screen, including lumbar puncture. All cultures came back to be negative. And CXR was done, but there was no new changes. The echo was normal. We did a ultrasound of the brain to find out whether the baby had any hemorrhage, but there was nothing, no new changes. There were some old changes, they were there. The antibiotics was stopped after 48 hours. The baby was observed for another 48 hours. The baby was all self-ventilating in air, feeding well, and the baby sent home. Next slide. Third admission. After 1 week, the baby again came to A&E with similar episode of choking and gagging. The baby was again apneic, blue, pale, limp. Baby was again admitted, resuscitated. We did a septic scan, which was negative. Next slide. On detailed inquiry, this time we were suspicious. What is happening? The baby was again and again getting admitted, but we are not getting any clue why the baby was getting admitted. The major factors we are all ruled out. The baby was not septic. The baby didn't have any brain hemorrhage. The baby didn't have any cardiac problem. The baby has not aspirated. The baby didn't have any pneumonia. But again, the baby had three admissions. But when we observed the baby, we found the baby was irritable. The baby was crying in between the feeds. And when we brought it, we found the weight gain was not satisfactory. And some of the senior nurses found the baby had lots of ming coming out or frothing out in between the feeds. And the baby was very much uncomfortable and arching back in between the feeds during day and night. Next, please. Keeping in mind, we have started thinking the baby had gastroesophageal reflux. We started the baby on proton pump or S omeprazole, and along with the other measures which should we have taken much before. So we have again reassessed the baby, again uh, uh, taught the parents how should we do that, the frequent burping, upward posturing of the feet, small frequent feeds. Next slide please. And the baby, next slide. And the baby was much better, and baby was comfortable, less vomiters, less pauses. The baby went home on oral S omeprazole, and the baby was regularly followed up. Until now, the baby has gained weight and no further episode, and we gradually weaned up the S omeprazole. Next slide. So, before we discuss the importance of gastroesophageal reflux and why we should know and why we should consider gastroesophageal reflux, in many cases, just a few words about the apparent life-threatening event or BRU. Now it is called, now name has changed to brief resolved unexplained event. So this is something we should know, an episode that is frightening to the observer and is characterized by some of the combination of. So it should be frightening. The parents should panic and they should bring the child as soon as possible to the A&E. And this should be done like that. Should be something which should panic the parents. So the baby should have a apnea or color changes. Apnea could be central or obstructive, could have color changes, could be blue, could be pale, could be absolutely red. There is changes in the muscle tone. Usually they are hypotonic, and there should be choking or gagging. Next slide, please. Next slide, please. and normally normally the causes are idiopathic. 50% cases we don't know the cause, and normally these are the causes of sudden infant death syndrome, because you don't know the cause. When they bring the babies, the infants, the baby is already, we couldn't resuscitate the baby. But rest 50%, if we distribute the rest 50%, most of them are gastrointestinal. and and if you see the cardiovascular, only 5%. So gastrointestinal is so important. Of that, gastroesophageal reflux is very, very important. Rest is neurological, respiratory, cardiovascular. So I wanted to emphasize one thing: those babies who come in the A&E with like acute life-threatening infect, many of them, especially the small tiny babies, has the gastroesophageal reflux, but they present like they have a cardiac arrest, they have a aspiration syndrome, they have some fits like things. But when you dig into things, that the all precipitating factor was a gastroesophageal reflux, but they presented like different way. They presented like a sinus baby, they presented like a choking baby, they presented like a baby with some syncope or some convulsion like that. So very, very important to keep in mind on your background that the baby can have gastroesophageal reflux. Next slide, please. Next slide. So before going to discuss about the gastroesophageal reflux and the difference between gastroesophageal reflux and disease, I will ask the $1,000 question. whether it is a disease. What is the, is it really a problem? Because some of my colleagues says that it is just a laundry problem, because the parents cannot wash that much of, you know, baby's garments. They use, uh, they give it to the laundry. So really, is it a laundry problem, or is it a smelly baby? Is it a spotty baby, or is it really something more? To me, it is not a spotty baby, or, you know, crying baby or smelly baby. The impact is more. It has got a huge impact on the parents, on the family, on the society, and on the huge burden on the economy of the country. Because if the parents suffer, the family suffers, the extended family suffers, the grandparents suffers, even the economy suffers. Because many of the parents, they cannot reach their uh, office in time. They are late because they have been awake throughout the night with the crying babies. So this is not a, although this is a one of the very physiological things, one of the basic uh, uh, one of the four basic things of the, which is called according to the Rome criteria, is one of the functional gastrointestinal disorder. But we should always treat with gastroesophageal reflex with proper respect and care, so that we just don't miss it. We treat it in a proper way, or we should uh, counsel the parents in a proper way. So, what is the basic difference the gastroesophageal reflux and gastroesophageal reflux disease? I don't have much time. So, in a nutshell, when it reflux is a normal physiological phenomenon, and when it is causes significant problem in the babies, then it is called gastroesophageal reflux disease. We added D along with GER, so then it becomes a disease. Next slide, please. Next slide. Yeah. So this is a very this is a picture just showing that this is how it happens. There is a splinter which is called lower esophageal splinter, or LES, which is protecting the acid going from stomach to esophagus, and the small babies up to 4 to 6 months. That splinter sometimes is spatulous, or is not contracting, so that acid uh, goes from stomach to esophagus, causing esophageal inflammation, and that causes that esophagitis and crying of the baby. So that's the whole pathology behind the gastroesophageal reflux. Next slide, please. So this is a very unhappy crying baby, because the baby has got reflux, the baby is vomiting, baby has pain in the throat, and baby is telling everything from the picture. Next slide, please. And this is a happy baby, much happier. This is a happy posseter. That was not a happy baby. This is a baby which is called uh, baby which is who are throwing up, posseting, but is a baby. This baby doesn't need any treatment. Next slide, please. So symptoms, we come across the symptoms every day: nausea, vomiting, regurgitation, failure to thrive, irritability with feed, feed refusal, because they know whenever I will feed, some of the feed will come up, and that will burn my throat. So this is a very sort of natural things. I will not take the food. Dysphagia, epigastric discomfort, and if it goes in such a state that causes some erosions in the esophagus and causes hematemesis. Some of them can come out as a melena, and those acid can come up and causes dental caries in bigger children. Next slide, please. Atypical symptoms, very important. This sort of uh, acid or things can some causes some sort of microaspiration, that causes wheeze, that causes intractable asthma, causes stridor, cough, as I says, ALT, uh, SIDS, sudden infant death syndrome, sleep disturbances, breath holding, Sandifer syndrome. What is Sandifer syndrome? This is a very unfortunate baby who has got so much esophagitis, so much of pain. The arches like a bow. So this is called Sandifer syndrome. I will show you a picture because what is happened? The acid, constant acid is going up because they have a very patulous lower esophageal sphincter. So acid is going up. So there are arches. So this is called Sandifer syndrome. That causes hoarseness of voice, laryngeal edema. Next slide, please. Next slide. So this is Sandifer syndrome. You can see this very unfortunate baby. Next slide. So, differential diagnosis, any sort of infection, peptic ulcer disease, intestinal obstruction, any allergy, could be cow's milk protein allergy, soy allergy, esophageal, is eosinophilic esophagitis, rumination, psychological problem. They are the very close DD of gastroesophageal disease. Next slide, please. Investigation. There's again $1,000 question. It's a clinical diagnosis. We shouldn't investigate to diagnose a gastroesophageal reflux. I mean, it is a shame if a physician investigate to stamp a disease as a gastroesophageal reflux. Uh, Investigate, but sometimes we have to investigate not to diagnose gastroesophageal reflux, but to exclude some sinister diseases. If you're thinking this child is having something else, the child is losing weight, the child is cachectic, uh, the child is quite wheezy, uh, I think the child has got something else. There is some red herrings. There is some red flags. In those cases, we has to investigate. Next slide, please. So what are the investigation? One is the barium. These are the old school investigation. We do it to exclude achalasia, esophageal stricture, hiatus hernia, any sort of obstruction, gastric outlet obstruction, intestinal obstruction. Next slide, please. Endoscopy. Unless you do the endoscopy, how could we uh, diagnose if there is some sort of allergic esophagitis like cow's milk protein allergy? They will present also like same sort of, they will present also like gastroesophageal reflux. If there is a stricture, they will present like a vomiting as well, or erosive gastritis, eosinophilic esophagitis. They all present like similar sort of things, but unless we do endoscopy, we cannot diagnose it. Next slide, please. Now comes the 24 hours esophageal pH monitoring. Next slide, please. So this is the gold standard for acid reflux. Mind the way, till recently, each point is important. Till recently, it was considered the gold standard for acid reflux. So, very important, acid reflux until recently. I will explain why these 2 points are important. And usually, PPI is stopped 7 days before study, and during 24 hours of study, meal feeding is reduced. Next slide. So this is a very easy method where the probe has been introduced and 24-hour study has been made. Normally, only few institutions uh, have the facilities of doing this 24 hours pH monitoring. Next slide. Next slide, please. Yeah, can be done in babies who is smaller babies also. Next slide. Next. Yeah, there is a scoring system. It's called Demeter scoring. So which gives a uh, which comes which has some parameters like recommend period, total period, number of episodes, longest episode, upright periods, and number of total episodes. Next slide, please. On that, the sum of all parameters allowed the diagnosis of pathological reflux when the threshold value is exceeded, and individual analysis of the parameters allow the diagnosis of reflux pattern. So there is a complicated graph. On that basis, one will say whether it is a mild, moderate, or severe reflux. Next slide, please. But there is a easier way to diagnose reflux by the North American Society of Pediatric Gastroenterology, Hepatology and Nutrition. They call it mild, moderate and severe. When the percentage of time when the pH is less than 4 is mild. If it is a pH is less than 4 in 5 to 10% of timing, moderate 10 to 20 and severe between 20 to 30. Next slide, please. Now comes the latest method, which is called multi-channel intranumular impedance. So this not only gives the idea of the uh, uh, about the pH, but also gives the bolus flow volume clearance and the moton pattern. So it is impedance. So it gives also the idea of the movement pattern of the movement, and most important, it gives, as I said, that was the normal pH monitoring allows us to give the idea of the acid reflux, but it gives the documents the acid reflux, weakly acid reflux, and also the alkaline reflux or the bile reflux. So that gives only idea when the reflux is acid, pH is less than 4, but it gives idea when the pH is less than 4, pH is between 4 and 7, and the pH is even more than 7, then also gives an idea. But it is a cumbersome process and it is not available in many places. Next slide, please. Next slide, please. Yeah. So this is the two sensor has been put. One is a gastric pH sensor, which is this is a tube. On the tip of the tube, one is a gastric pH sensor, and 5 centimeter above the tube, one is esophageal pH sensor has been put. There is a sensor which is called esophageal pH sensor, and 3 centimeter, 5 centimeter, 7 centimeter, 9 centimeter above the tip, it gives an idea about the distal reflux, and 15 centimeter and 17 centimeter it determines the proximal reflux. Next slide, please. Next slide, please. So this is the why this pH monitoring is superior to multi-para pH monitoring is superior to normal pH monitoring, because this gives uh, first one, the plain pH monitoring gives idea only about the acid, uh, uh, but the multi-channel internominal pH monitoring gives idea about the non-acid reflux, gas reflux, bile reflux, and it gives the idea about the bolus clearance, chemical clearance, everything. So it is not only, it's a dynamic thing. It not only gives idea. First one is the pH monitoring is a static. It gives idea about only the pH, but the multi-channel internominal impedance. Impedance means it gives the idea about the bolus movement, how the gut is moving as well. So it's a combination of static and dynamic. Static means it gives the idea of the pH, at the same time it gives the idea about the movement, bolus movement of the fluid inside the gut, how it is moving from stomach to esophagus and going up along the esophagus. But the its cost is very very high. So pH monitoring is cheap, it is expensive, interpretation is very easy. pH monitoring, a curve will come out automatically, but for the multi-para or multi-channel internominal impedance, it needs somebody, to some expert, to interpret the curve. So but it is much much advanced and it gives more information about the gut. Next slide, please. So I'm running short of time. Very quickly about the management of GERT. So non-pharmacological and pharmacological. Next slide, please. Next slide. So non-pharmacological, very important mainstay of management of gastroesophageal reflux is non-pharmacological, especially in infant, explanation and reassurance. This is very important. I I can spend hours, and I normally spend many hours with the parents about the explanation and reassurance. I take a piece of paper and draw them and again explain how it happens and what should be the posture and exactly what will happen. So I will tell you the story exactly what happens. It may take a couple of minutes, but again I have to take that. What will happen? They, when the baby is hungry, start like that. They will feed the baby. The baby had reflux. The baby, the stomach is full. They are feeding the baby. That milk is going up to the from the stomach to esophagus. That causes, because that the sphincter is not is patent, sphincter is spatulus, so that causes burning in the esophagus. It causes esophagitis. That causes crying. Parents thinking the baby is hungry, they are pushing another milk, again that is going up to the esophagus, again the baby is crying, so that again the baby started vomiting, spitting again maybe, and the parents thinking the baby is hungry, they are putting more milk. So it's a vicious cycle. Baby continuously crying and vomiting. They are thinking, oh, baby is vomiting out. They must be hungry. Their stomach is empty. So we need to give more milk. So this is a vicious cycle. So I explained to them, give small frequent feeds, burp them, but not. But there are some posture. Sometimes I see they are putting them in a car seat, infant carrier, absolutely bad posture, semi-seated posture that causes pressure on the tummy. Don't use those posture. Sometimes they put the head on a pillow, two pillows. What will happen? Again, that causes pressure on the tummy. Don't use that. If you want to elevate, elevate the head end of the bed, not the head of the baby. Head end of the bed means put some bricks under the bed, not the head of the baby. Again, that curves the baby, pushes pressure on the tummy, and that again causes milk to go up to the from the stomach to esophagus. So that's very important. So that give time for the some time to explain the pathophysiology, and say when the baby will start sit, when the baby will start crawl, when the baby will start walk, stand and walk, automatically it will go off. That will give lots of pleasure, lots of satisfaction, lot of confidence to the parents, because they will think this is a lifelong thing. Say this is the gravity. Gravity will take care of many things. So medicine will not need it, but the gravity will take care. Next slide, please. So older children, again the lifestyle changes, quit smoking, quit coffee, quit carbonated drinks, eliminate tight fitting dress. Next slide, please. First stepwise approach. First is, as I explained, the postural things, etc. Second is the antacid, alginate, prokinetics, and then H2 receptor blocker, ranitidine. Next slide, please. Does not happen, then proton pump inhibitor. Even does not happen, then add prokinetics, and last stage surgery. Next slide, please. Surgery very rarely needed. Next slide, please. Normally, this is called Nissen's fundoplication. This is the age-old surgery where they wrap that end so that the stomach and the obviously uh, fluid cannot come. That fundus, they tie the fundus so that they cannot come, but they have to put a gastrostomy, alpilostomy, to make a secondary way to feed the baby. This is a temporary one. This is for the severe gastroesophageal reflux, especially the patients who are who are maybe some of them has some neurological problems, some spinal problems. So from them only those are needed. Next slide, please. So there is a lots of complication. As I say, most is a faltering growth, esophageal stricture, hematemesis, recurrent iron deficiency anemia, aspiration, Sandifer syndrome, and sudden infant death syndrome. Next slide, please. Take home message. So happy splitters. This is very important. Doesn't need any investigation. Gastroesophageal reflux, relevant investigation is justified if you think there is some red flag signs. Multi-channel intraluminal impedance is a gold standard but not easily available. Non-pharmacological management is the mainstay of treatment. Medication is needed only in few cases. Next slide. I think that's all. Thank you for very much for your patience listening. I am open to any questions if you have.
Thank you, sir. Thank you so much. That was a very insightful presentation, I would say. And, sir, with your permission, we have received a few queries. I would like to take maybe two or three of them.
Sure, sure. Yeah,
Yes, sir. Sir, the first question is, in clinical practice, how can we differentiate between a happy speaker with simple GER and a child with GERD who requires further investigation?
uh, I think we'll start from the history and examination. In the happy speaker, normally about the first of all, I think the best option will be we have to plot the child. We have to take the history exactly how much the baby is splitting exactly, and then we have to take the height, weight, and plot the baby. If the baby is thriving, gaining weight, baby is otherwise happy, we'll think it's a happy splitter. But if the baby is not thriving, then we have to think that there is something wrong, and we have to start investigating the baby.
Thank you so much, sir. The next question is, among the diagnostic tools like barium swallow, pH study, dependence monitoring, and endoscopy, how do you decide which test to prioritize in infant with suspected GRD?
I think the easier obviously is the barium and the pH study, because endoscopy is invasive, and we have to refer it to the pediatric gastroenterology. And pH impedance, as I say, is multi-channel impedance study, only available in some tertiary centers. So initially, the barium to exclude some obstruction, some strictures, etc., etc., and pH study is now available in many of the hospitals. Just a overnight stay, and that gives a very good idea about the reflux.
Right, sir. One last query. So, in what situation do you consider surgical options like fundoplication, and what are the long-term outcome for children undergoing such intervention?
As I said, this is very rarely needed, especially those who have got some background, like those have babies who has got some spinal muscular dystrophy, who have got some spinal surgery, some cerebral palsy. Those children who have got refractory gastroesophageal reflux, those who cannot keep anything down. Even initially, we should try hourly feed or continuous feed as we normally do, with a with a NG feed or gastrojejunal or gastro nasogastric or nasojejunal feed. Even those who cannot keep anything down, has severe reflux, in those cases we need to do the fundoplication and gastrostomy. And normally the problem with that is the stoma and care of the stoma, and we have to change the tubes very frequently, and there is a chances of infection around the stoma. But with stomach care, now it's a different sort of domain, and the stomach care nurses are available, and many stomach care bags are available now. Those are very, very helpful. Now we have got very advanced care for that. So with that, I think those children are quite happy now. They are with that stomach care bag. They are now enjoying a normal life. They are going to the parties. They are doing everything now. So with that happy note, I should say we have advanced quite a lot, and we are giving them a very sort of happy and significant, meaningful life. And so I think we are doing quite well in those in that sense.
Thank you, sir. Thank you so much for answering all the queries. On behalf of the IGCP team, I extend our gratitude for sharing your expertise and valuable clinical experience with us today. I'm sure the audience has gained a lot of useful takeaways from your talk, sir. So, thank you once again, sir. We look forward for such enlightening sessions in the future also. So, with that note,
Thank
sir,
you.
I would like to conclude here. Thank you.
Thank you. Thank
Thank
you,
you.
audience. Thank you very much. Thank you. See you then. Bye bye. Bye.
Yes, sir.
Bye.
Thank you so much, sir.